PSMA is a novel treatment modality for patients with prostate cancer, metastatic castration-resistant prostate cancer. PSMA is a target, is a protein that is overexpressed at the surface of the prostate cancer cell at high level. And so we use that target as an anchor for targeted treatments. Targeted radioligand therapy or targeted molecular radiotherapy delivers locally radiation therapy to the cells that express that target. So it's really a targeted approach. So in theory, you can have better treatment effect on the tumor cells with less toxicity on the non-targeted organ because they do not express the target. So that's the key, the first part. The second part is you can also use the target for imaging agents. Instead of using a therapeutic radionuclide, you use an imaging radionuclide. And so you can visualize where the target is and then subsequently potentially treat it. So that's the theranostics approach. That's really what is a booming field currently. Since I would say 2015, we have multiple theranostics studies and products and companies that are really being developed, and that's what is very novel. So PSMA has been approved for patients in second line with metastatic castration-resistant prostate cancer. Now it's moving earlier. We're trying to improve the use of this new therapy agent, how to refine its use with the combined imaging agents, and also there will be other targets in the future. So that conference is only about PSMA because there is already so much to say on the imaging part and also on the therapy part. We have gathered all the best experts who work on that during the past 5-10 years. So it's really nice that we can highlight that and make a specific conference just to PSMA targeted theranostics. Both on the diagnostic efficacy and the therapeutic efficacy side, multiple studies paved the way for bringing PSMA theranostics approach from clinical research to clinical approved standard procedures now. And there are indications that are set. Primary staging of high-risk prostate cancer for PSMA PET, localization of biochemical recurrence of PSMA PET. For treatment, it's second-line metastatic castration-resistant prostate cancer who failed chemotherapy. Now, the next step will be to change a little bit these indications, moving the PSMA treatment at earlier disease stage, before chemotherapy maybe, or even earlier. For imaging, it's maybe how to refine the analysis in the prostate gland, for example, because there is no indication for biopsy yet. It's how to refine the criteria for therapy, systemic therapy response assessments, because it's not easy to assess response to systemic therapy with PSMA PET. So these are the big boxes. And then in each of that, you can ask multiple questions, run clinical trials to see, for example, if one PSMA PET finding, which is a new information that did not exist before, how to treat that. So you can try, based on the same PSMA PET pattern, different types of treatments and follow the patient and see how it works the best to know how to use, at best, this new information that wasn't existing before. For the therapy portion, the ideal patients are the ones who do not have lesions that do not express PSMA. The more the disease progresses, the more heterogeneity can occur. Some lesions can lose the PSMA target expression, and of course the radiopharmaceutical delivery will not occur. There will not be enough treatment on these cells, and it will make them progress because there will be a selective pressures on the other target expressing cells and not these ones. So this, what we try to look for when we do the screening for PSMA targeted treatment. We do the PSMA targeted PET imaging, and we chase for these non-PSMA expressing lesions. And for that, then we can either orient the patient to another treatment modality or do combination therapy with radiation therapy. There are several options, but these are really the ones that for who it doesn't work very well. Again, I think it will move at earlier disease stage. Until which early disease stage, I don't know, but for sure, I think studies will show efficacy, before chemotherapy and not necessarily failing after chemotherapy. We'll see also maybe studies in the castration-sensitive space. That's also possible. And then there is a lot of improvement we can do in the use of the treatment molecule, how to administer it, the amount of it. Now it's fixed injected activity, 7.4 gigabecquerel 6 times every 6 weeks. I think we can refine that. Maybe some patient can have treatment holidays. Maybe some patient can have treatment intensification. You would do back-to-back, 1 week apart, 2 doses if there is a need for intensification. The use of dosimetry. So the refinements of the use of lutetium PSMA may occur in the next 5 years. I hope so.